Aloha, everyone, and thank you for joining the COVID-19 Public Health Action Webinar, COVID-19 Vaccinations for Keikis ages 5 to 11. My name is Makamai Namahoe, and I'm with Hawaii Public Health Institute. Before we get started, there's some Zoom housekeeping to go over. For all questions, please utilize the chat box or questions and answer box located at the bottom of your screen. No continuing education credits will be provided during this webinar series, and all webinars will be available on the Hawaii Public Health Training's YouTube channel listed here. So without further ado, I would like to introduce to you our presenters for today. Dr. Janet Behrman. Wait, Alana, can you go one screen back, please? Okay, so Dr. Janet Behrman is originally from California and trained as a pediatrician at UCSF. She worked as a general pediatrician in American Samoa for 4 years, and in 1992 was one of the first pediatricians to join Waianae Coast Comprehension Health Center on Oahu, where she practiced until 2003. During that time, she mentored medical students and pediatric residents at UH-Jabson in her role as clinical faculty. In 2003, Dr. Behrman returned to California, where she completed a Master's of Public Health at UC Berkeley. She served as the City of Berkeley's health officer for 10 years. Her experience there included managing a large university-based mumps outbreak, leading the local response to the swine flu pandemic, and ensuring the quarantine and monitoring of travelers exposed to Ebola virus in West Africa. Returning to Hawaii as the Kauai District Health Officer in 2016, allowed Dr. Janet Behrman to combine her rural Pacific Island primary care experience with health expertise she gained in California. The COVID-19 pandemic has provided an opportunity to apply her experience in disease outbreak control. Our second guest speaker is Dr. Douglas Guak, who is a pediatrician at Kapi'olani Medical Center for Women and Children and the Vice President of Medical Affairs for Hawaii Pacific Health. A practicing pediatrician for more than 20 years, Dr. Guak has also held various leadership roles for Hawaii Pacific Health, including Chief Medical Officer for Palimomi Medical Center, Associate Chief Medical Officer for Hawaii Pacific Health, Medical Director of Kapi'olani's Alapono Quality Program, and Vice Chair of Kapi'olani's Pediatric Department. He has also served as both a board member and a chair of the board for Kapi'olani. Dr. Guak received his medical degree from the University of Hawaii John A. Burns School of Medicine. He completed his residency in pediatrics at Duke University and a fellowship in pediatric infectious diseases at Stanford University. He has been a key member of the physician leadership guiding Hawaii Pacific Health in its COVID-19 response efforts, including COVID-19 protocols, treatment, and vaccine clinics. So I would like to turn it over to Dr. Janet Behrman.
Thank you very much, Maka, and thank you everyone who's on the call. Let me share my screen and we will get started. Okay. Technical experts, please let me know if that's not sharing, but it looks to me like it is. So we are going to talk about childhood vaccines, vaccinating keiki ages 5 to 11, and we couldn't have had better timing for this. So I have a little more to say than I probably have time to, so I will talk a little bit fast. Dr. Guak is actually going to cover some of the same material that I have in more detail, so I'll try to go more briefly over those slides. Let's see. I wanted to, just as an overview, talk today about the public health perspective on COVID disease in young children. And that's really where I'll spend the bulk of my time. I also wanted to talk a little bit about decision-making around this, both how parents individually make those decisions and also how agencies and policymakers make decisions about new vaccines like this. And then some very practical information, just a little bit about next steps. So in terms of the public health perspective, I want to put this in the setting of the pandemic to date. And this is the epidemiologic curve of the pandemic in our state, going back to the beginning of last year, 2020, and with this big spike here being, as you know, this last summer when we had our highest surge. And I think it's important for people to see both how much larger that surge was than our experience earlier in the pandemic, and also to understand that in Hawaii, we have really been spared the overwhelming impact of the pandemic in the way that it's been experienced in most of the rest of the country and the rest of the world. So even though it has felt very impactful to us, we have been fortunate and we continue to be fortunate. And it's our actions and policies that have kept us as safe and healthy as we've been through the pandemic. So when I say I'm going to talk about the public health perspective on COVID in children, and especially in young children, I'm talking about the epidemiology, which is the pattern of disease and the impacts of those diseases, of that disease, not only on the children, but on everything around the children. So I'm going to talk in that context about disease frequency and severity. And spoiler alert, yes, children can and do get COVID and can and do spread it to other people. It's also important to understand that the pandemic and COVID infections and everything associated with that has a real impact on social and emotional well-being and of course on learning. It also has an impact on families and our communities. And finally, it wouldn't be a public health I wouldn't be providing the full public health context if I didn't talk a little bit about equity and about the uneven distribution of disease and its impact in our communities. So to talk about the first of those things a little bit more, the disease in children, and I'm going to talk about this more from a population level than an individual level, but some on the individual level. As I said, children are getting infected with COVID-19. And I think it's important for all of us to know that although it's generally more mild than it is in adults, the disease can be severe and result in hospitalizations and even death in children. Children can develop long-term effects from COVID. And children, especially young children, are making up an increasing proportion of the disease burden in our communities. And they also can spread disease to high-risk individuals in their family or friends or other people. So the disease has impacts on the child, him or herself, and on those around the children. So these are Hawaii data for the pandemic from the beginning till now. And this slide, which is on the Department of Health's public website, shows for each age group indicated at the bottom, the numbers of cases of individuals who've had COVID-19 who have just been a case and have not had any, not required hospitalization and have not passed away. And then the lighter green is those who've been hospitalized, and the kind of pinkish brown is the deaths in each age group. So it is certainly true that in the 0 to 17 age group, we see much lower levels of hospitalization and very few deaths, but the number is not zero. And that's important for people to know. Even here in Hawaii, about 1% of those under 17 who've become ill with COVID-19 have required hospitalization. And the Department of Health is close to a final analysis of the data for those under 12, and those will be forthcoming soon, but not yet today. Nationwide, there have also been deaths in this age group. In Hawaii, we have been fortunate, and that's been minimal. I believe there's only been one death of a child in our state, but again, it's not zero. Long COVID, I don't have Kauai specific data on this, and of course it's still evolving, but a study out of the United Kingdom showed that, as you can see, 7 to 8% of children still had symptoms as long as 12 weeks or 3 months after their diagnosis. And it's important for people to understand that that's not related to the severity of the initial disease. So a child can have a mild disease and still go on to develop and have symptoms that last for many weeks or months afterwards. And the symptoms of long COVID in children are similar to those in adults. This is where I think the epidemiology of the disease and the disease patterns are really important for people to understand. So this is Department of Health data here in the state of Hawaii. And you can see this graph goes back to July of this year. So since July, as we know, we saw an ever increasing number of cases through the end of August. And cases increased both in adults, shown here in the blue, and in children under 18, shown here again in that kind of pinkish brown color. So as cases increased, they increased across the age spectrum. And as they've decreased across the age spectrum. But what I'd like you to look at is the percent of cases that were children as opposed to adults. So back before this big surge, the percent of cases that were children was about 20%. At the peak of our surge, children made up about 24%, so about a quarter. And in the most recent period, children make up 28% of the total cases. So the proportion of our cases statewide that is children is increasing, and it's now approaching a third. We're not quite there yet. And of course, children under 12 are those who can't be vaccinated. And this is another way of looking at those data, but this separates out the 12 to 17-year-olds, which are the purple line here, and those under 12, which is the orange line on top. And what you can see here, this goes back a little further to May of this year. The proportion of all cases that involve 12 to 17-year-olds has been pretty stable across this whole time period, even through the surge. But as we've vaccinated more and more people, including 12 to 17-year-olds, the proportion of our total cases, that is those under 12 who are not eligible for vaccination, is getting greater and greater and greater. And that's what we would expect, because the virus can spread more easily in unpopulated populations. So children are forming a greater and greater part of the pandemic picture, if you will, at home here in Hawaii. These are Hawaii data too. And of course, the disease itself is one thing, but there are lots of sort of ripple effects of either being infected with COVID-19 or being subject, in which case you have the illness and you're also subject to isolation, or being exposed to it and unvaccinated, in which case you're subject to quarantine. And those children miss out on all kinds of social and emotional and educational opportunities in school and outside of school and with family and friends. And that in turn increases stress on children and their parents, their families and caregivers. And we have seen an increase in reports of concern to Child Protective Services in the course of the pandemic. So we know that the ripple effects of the disease are really important and significant, and not something to be cast aside. Just a little bit of data about the educational impacts. These are DOE data from their annual STRIVE data analysis or report. And one of the things they look at is the percent of students who finish school and go on to post-secondary education. And that's been 50% in the last year, and it was 55% prior to the pandemic. And then if you look at proficiency in the various areas that are assessed, language arts and math and science, you can see that in 2021, when there was the full impact of the pandemic, there was a substantial decrease in the proficiency in all of those areas. And one can argue that we weren't doing all that well to begin with, and a 10% loss in math and science proficiency is really significant and has an impact not only on our students and their families now, but on those young people as they grow up and move through their education and careers. And then I touched on this before, but of course it's not just the children, it's their families and the broader community. When children have to stay home because they're sick or they're in quarantine, their parents and caregivers miss work. That puts financial stress on the adults in the family. It also puts emotional stress on adults and family. And just as with reports of child maltreatment, we've seen increasing risk of domestic violence and increasing risk of use and abuse of substances, including alcohol and other drugs. So again, the impacts are much greater than than the data about cases may show us. And then talking just a little bit, as I said, about equity and disproportionate impacts, we know that the historically underserved populations on Hawaii suffer a disproportionate burden of chronic disease, have more difficulty accessing culturally appropriate healthcare, and have more difficulty accessing basic resources for living, such as those listed here: housing, income, food, education, and even transportation. And COVID-19 has been no exception to that. So the burden of this disease, both those social, emotional, and educational burdens and the disease burdens, have been disproportionately and continue to be disproportionately felt here in Hawaii. The Department of Health looks at as much data as we can by race and ethnicity, and we don't have as much granularity or as complete reporting on this as we would like. But this is a screenshot from the Department of Health's public data website, so you can look at this and explore it a little bit on our website if you're interested. But what I put here was just the cases of COVID-19 since the beginning of the pandemic, broken out by race and ethnicity. And the bluish green bars are the percent of the total cases that occur in the specified race or ethnic group. And the gray bar is the percent of our state's population that that group makes up. So if the distribution were equal, we would expect to see the green bar and the gray bar at the same height in each racial and ethnic group. And that's not what we see. In fact, what we see, if you look at Native Hawaiians here, the second pair of bars from the left, our Native Hawaiian population makes up 29%, almost 30% of the cases of COVID-19, but just over 20% of our population. So there's almost a 50% overrepresentation of Native Hawaiians among those who are having COVID-19 cases, infections. Similarly, with our Pacific Islander population, the state's population is approximately 4% Pacific Islander, but the COVID cases have been 8% Pacific Islander. Similarly, with the Filipino population, there's a 3 percentage point difference. And of course, if some groups are overrepresented in illness and disproportionately impacted, other groups are disproportionately privileged and protected. And we see that among our ethnically Japanese and ethnically white populations here in the state of Hawaii, as well as Chinese and other Asian. So when public health people talk about equity, we're really talking about this whole package of disproportionate impact in many, many ways on the same populations over and over and over again, which has a cumulative effect. Shifting gears a little bit from the demographics and the public health epidemiology of things, I wanted to talk about decision-making, both by agencies and policymakers and by individuals and parents and guardians. So many of us have become much more familiar with the FDA and the CDC and their processes than we ever were before. And for many of the listeners, probably more than they ever wanted to be, but it's been in the news so much. We know the FDA does its review and authorization first, and then the Centers for Disease Control makes their recommendation, and then we move forward. So last week, the FDA completed its review of the safety and effectiveness of the vaccine in children 5 to 11, and they found that it was effective and that it was safe. And so they authorized its use in this age group and passed that information on to the Centers for Disease Control. And then, as you also likely know, just yesterday, the CDC's advisory committee and subsequently the director of the CDC, Dr. Walensky, recommended use of this vaccine in this age group. And that's the green light for our healthcare partners to go ahead with administering the vaccine and for our policymakers and agencies to develop their recommendations and regulations at some point potentially around this vaccine. So parents of children 5 to 11 are now needing to answer the question of whether or not they will vaccinate their children. And children are not vaccinated without the express written consent of a parent or guardian. So this really is a decision that ultimately rests with the parents and guardians. And I thought I would quote Emily Oster. She's an economist, actually. She's not a healthcare professional. She writes for the Atlantic Monthly, and she's written about vaccine issues. And she recently was asked whether she would vaccinate her own children. And this is her response. I've quoted it. She said, yes. And she said, there are lots of reasons I would do that. I don't want them to get COVID. I'm worried that they may infect their immune compromised grandparent. I'd like to avoid quarantine and keep my kids in school. And I'm confident in the vaccines and the FDA process. So those were the things that really rose to the surface for her and contributed to her decision about whether or not to vaccinate their children. And each parent who's making this decision will give different weight to different considerations. But I think that's a good starting point for the kinds of things to weigh in making the decision. Other things that I think parents may put into their decision-making mix are concerns about long COVID, concerns about their children's ability to participate in activities outside of school and to socialize with family and friends. Some parents may be concerned about their access to healthcare resources should their child become ill and want to prevent the small likelihood or the small possibility of a hospitalization or severe illness. And other parents might be concerned about the fact that the therapeutic options, the treatments for COVID-19 in young children are actually more limited than they are in adults. So each of us is going to weigh those things separately. As a pediatrician and a public health physician and a mom, I've had lots of these conversations, and I know how complicated the decision can be. And I think that most parents really are out to do the right thing for their children. So that is reassuring to me. I also want to talk a little bit about the last box on this slide about the good of the whole, because there's really, I can't think of a single, and I was trying before the talk, I can't think of a single thing that we have asked people to do, or we have been asked to do, or a regulation or a restriction or a requirement or a limitation that's been put in place to control the pandemic that wasn't about two things. All of those things have been about what's good for you as an individual and what action can or should you take to protect yourself, but it's also what action can or should you take to protect our whole community. So when I say the good of the whole, I mean all of us who live here. And I would hope that parents who are making these decisions are including in their decision-making certainly the well-being of their child first and foremost, and also considering each of our responsibility as members of a civic society who all live together and all do bear some responsibility for the greater well-being of all of us as a community. So that was the preachy part. Sorry, this is the very practical part, and I'll get through it very quickly. So what are we doing now? We're, as they say, getting shots in arms. Over 40,000 doses of the pediatric vaccine are already distributed throughout our state. They're in hospitals, they're in clinics and federally qualified health centers. They're in some pediatricians' offices, and they will be in pharmacies, and they're available even today. And Dr. Kwok can tell you more about that. That's the initial order. It's enough to give a first dose to about 35% of the eligible children. There are almost 120,000 5 to 11-year-olds in the state, and the hospitals can order more vaccine as they need it. There's no concern at this point about any shortage or limitation of availability of the vaccine. The dose is 1/3 that for adults. There's a smaller needle also, which is probably good news for the kids. And this is very routine in pediatric practice for medications and vaccines to be in a reduced dose for younger children. And then the final thing I wanted to say is that the responsibility for overseeing the safety and effectiveness of vaccines doesn't stop when we start giving the vaccine to people. It's an ongoing process, as you are probably aware with adult and adolescent vaccinations. And one of the monitoring tools that we have in place is VAERS, or the Vaccine Adverse Event Reporting System. And what many people don't realize is that that's a system that anybody can make a report into. You don't have to be a doctor, you don't have to be a healthcare professional. Members of the public, patients, parents can submit a report there. So if anybody is aware of or concerned about a possible untoward reaction to a vaccine, that's the place to make the report. And that allows the CDC to monitor for any red flags about patterns of adverse reactions that can then be investigated further. And that's how we learn about very, very rare but important side effects that may emerge that haven't yet. I will say that these vaccines have been given to millions of people over nearly a year now with extremely reassuring safety profiles, including to very young teenagers. So I think that Dr. Kwok and I would both say that we feel confident as pediatricians moving forward with this younger age group, and we always have the responsibility to continue monitoring for any adverse events. Thank you all very much.
Hi there. Can everybody see my screen okay? Okay.
Yeah, we can see your screen.
Okay, perfect. Dr. Berryman, that was an excellent discussion. And I think it's great that a lot of the topics that you and I are going to talk about kind of overlap. But I'm going to talk about this topic from a little bit different standpoint, not necessarily from a public health standpoint, but from an individual standpoint in terms of what can providers think about in terms of how they have discussions with parents on vaccinating their children, and what can parents consider with regards to making a decision on how they decide to vaccinate their children. So a little bit different slant. Okay, and I'm going to start with the impact of COVID-19 on KEIKI. And just as Dr. Berryman stated, children are at least as likely to be infected with SARS-CoV-2 as adults. And children tend to exhibit milder infections compared to adults, but you put the two together and what it's created in the community is a perception that KEIKI either don't get infected as much, or their infections are so mild that it's okay for them to to not necessarily get vaccinated or get protected, when that's actually not the case. Because when you look at that third bullet point, since the beginning of COVID-19 pandemic, among US children ages 5 to 11 years of age, there have been 1.9 million cases in this age group, 8,300 hospitalizations, 2,316 cases of MIS-C, which is referred to as multi-inflammatory syndrome in children. And these are immune-mediated complications of a COVID vaccine, of a COVID infection that occur about 10 to 14 days afterwards. And there have been 94 deaths in the 5 to 11 year age group. So while people tend to think of children as getting milder infections, or maybe not getting infected as much as adults, they can get infected as much as adults, and their infections can be quite severe, as we know about 94 parents and family members that are involved in those deaths. So COVID-19 infection can certainly impact KEIKI. And then Dr. Berryman had a great discussion on how it impacts other aspects of KEIKI in terms of social, emotional, and mental welfare, education, physical activities and sports activities, social interactions, and play sessions and whatnot. So these all affect our children in different ways aside from the infection alone. And so what can we do about it? Well, this is a day that a lot of us have been waiting for with regards to vaccinations being available for 5 to 11-year-olds. And the most recent developments over the past week has been that Pfizer BioNTech got a COVID-19 vaccine authorized for 5 to 11-year-olds at 1/3 the dose of an adult Pfizer vaccine. The doses are given in 2 doses, 21 days apart. So in that sense, the schedule is the same as adults. And so following those authorizations from the FDA and the CDC, the American Academy of Pediatrics, which is the governing professional society for pediatricians, came out with recommendations for vaccinating 5 to 11-year-olds. And it is that COVID-19 vaccination is recommended for all children and adolescents 5 years and older who do not have contraindications to the vaccine. There are primarily 2 contraindications to the vaccine. One is if you've had an allergic reaction to the first vaccine, you shouldn't get the second, or you should get a different formulation, maybe the J&J vaccine for the second, or if you are allergic to any of the components of the vaccine. So if you have any questions about that, consult your pediatrician. Children with prior COVID-19 infection or disease should still receive the COVID-19 vaccination. And that is because we're not sure about how good an immune response is mounted in children, especially those children with asymptomatic infections. So as a result, it is still recommended to get vaccinated, even if your child has had the infection or the disease. And it is okay to co-administer COVID-19 vaccine with other routine childhood vaccines, understanding that, that routine childhood vaccines are just as important. So there is no time frame with regards to separating immunizations. You can get them all at once, or you can get COVID vaccine a day or 2 after you've gotten other vaccines. Just make sure it's given in a different site. If you got COVID vaccine in one shoulder, get a different shot in the other shoulder. Now I'm just going to go over the authorization process that Dr. Berryman went over, but just mainly to highlight a couple of several points. And how the process worked out is that Pfizer conducted clinical trials of the COVID-19 vaccine to study the safety and effectiveness of the vaccine in 5 through 11-year-olds. And what they found in their studies in terms of a safety standpoint was that there were no serious side effects that were detected. In particular, no cases of myocarditis were detected. There were common side effects that were detected. That was fatigue, muscle soreness at the injection site, headaches, and those were found to be the same as adults. Those symptoms typically subside maybe 1 day, 1 to 2 days after you receive the vaccination. And in terms of how effective this vaccine was in 5 through 11-year-olds, it was 90.7% effective in preventing COVID-19 infection in children 5 through 11 years of age. So Pfizer conducts these clinical trials and then they submit the data to the FDA. And the FDA reviews this data and decides on authorizing the vaccine on whether the totality of the scientific data that is presented demonstrates that the benefit of the vaccine in terms of safety and efficacy far and away outweighs the perceived or risks of the vaccine presented in the study. So the FDA has an advisory committee, which is composed of community physicians and community scientists that discuss this and give their recommendation. Once the FDA authorized the vaccine, then the CDC provides clinical recommendations on how the Pfizer vaccine will be administered to the 5 to 11-year-olds. The CDC also has an advisory committee consisting of community physicians and community scientists. So just so you understand, this is a very, very public process, and these advisory committee meetings are all publicly posted so that anybody can listen in on these meetings. The point I'm trying to make is that this is not a political process in terms of authorizing and administering vaccines. It is not a financial process of authorizing or administering vaccines. It is a scientific process based on data and research. And it is very transparent. Again, anybody can listen in on these advisory committee meetings if you happen to have 8 to 10 hours lying around to listen. And then just as Dr. Berryman stated, just because these vaccines are authorized and beginning to be administered to the public does not mean that monitoring of these vaccines stop. It's actually when the monitoring really ramps up, because now you're giving the vaccine to a much broader community. So there is absolutely ongoing monitoring. And for anybody who is getting the vaccine or is considering getting the vaccine for their children, download that vSafe app, which is a CDC app, onto your smartphone. The CDC will monitor for symptoms and they'll ping you via text messages. And also you can report any side effects to the CDC directly through that vSafe app. And then there's the vaccine adverse events reporting system, VAERS, which anybody can report to, not just physicians, but patients and parents and guardians alike. Anybody can report, and you don't have to demonstrate that what you're reporting is associated with the vaccine. Any occurrence that could be considered associated with the vaccine should be reported, and the CDC and the FDA will determine whether there is a link between that event and the vaccine. There's also the vaccine safety data link and clinical immunization safety assessments, which are networks which continue to do in-depth monitoring and data production. So ongoing monitoring of these vaccinations once we roll it out to the public. I happen to have had 8 to 10 hours to spare to listen to these advisory committee meetings, and I'll tell you, a large part of those advisory committee discussions were based around the risk of myocarditis. That was something that the committee members were very mindful of and very aware of, and wanted to make absolutely sure in the 5 to 11-year-olds that it was a consideration and that is being monitored. And the reason why is because in older individuals and those that are able to get the vaccine, 12 and up, there have been about 20 cases per million COVID vaccine doses of myocarditis associated with the vaccine. primarily occurring in males, primarily in ages 12 to 24 years of age, and primarily after the second dose, typically occurring maybe about 7 days after receiving the vaccination. The vast majority of myocarditis cases associated with the vaccines have not been severe, have actually been mild. The majority of the cases have actually recovered at home without any specific intervention or medication. And then some individuals have been required to take ibuprofen for pain management. So, though the risk of myocarditis is real in about 20 cases per million, the myocarditis that occurs with the vaccine has been mild and not severe at all. Now, in the excuse me, in the 5 to 11-year-olds, the study did not demonstrate any cases of myocarditis in that age group. But that does not mean that that myocarditis is not a consideration. So there is anticipated to be a lower risk in 5 to 11-year-olds than older individuals. And the reason why is because there is a natural lower baseline incidence of myocarditis in younger individuals. And because the dosage is a third of the adult dose in the 5 to 11-year-olds, it's thought that if there are cases of myocarditis as a risk, that it would be much lower in this age group. Now, kind of bookending the vaccine-associated myocarditis is myocarditis associated with COVID-19. COVID-19 can cause myocarditis, and with multi-inflammatory syndrome in children, you can get myocarditis side effects. So, myocarditis is a very real effect of the infection in and of itself. And COVID-19 associated myocarditis is much more severe than vaccine associated myocarditis. So those are all things to consider when parents hear about myocarditis and consider whether their 5 to 11-year-olds should get vaccinated. It's a safe medication. There were no cases that came up. The vaccine associated myocarditis cases are not severe relative to the COVID-19 myocarditis cases. So when you do immunize your 5 to 11-year-old, I would just say make sure you're looking out for these symptoms: fatigue, pounding or fluttering of the heartbeats, shortness of breath, and chest pain. If you notice any of those things within the week after your child gets a vaccine, consult your pediatrician or physician. It could be one of those rare incidents of myocarditis associated with the vaccine. And then just one other couple points I wanted to point out with regards to the mRNA vaccine, because Pfizer is an mRNA vaccine. And these are some concerns I've heard from other parents with regards to getting vaccinated. No, the vaccine does not affect the individual's genetic material. The vaccine is RNA, which is the blueprint for making the spike protein, which generates the immune response in the host individual. This mRNA does not enter the nucleus of the individual cells, and it does not interact with the individual's DNA. So there is no genetic effect. And this last point, I know it doesn't necessarily pertain to 5 to 11-year-olds, but this has been a concern in pregnant women and breastfeeding women, in that the vaccine does not adversely affect pregnancy or breastfeeding. And in fact, the American College of Obstetrics and Gynecology strongly recommends vaccination during pregnancy and breastfeeding. And the reason why is, on the flip side, there is a benefit to actually vaccinating during pregnancy and breastfeeding. If you vaccinate during pregnancy and you develop immunity and antibodies to the spike protein, conveying protection against COVID-19, those antibodies actually cross over into your developing baby. So your baby is actually born with some protection to COVID. And if you're breastfeeding, some of those antibodies that you developed from your vaccine actually come out in your breast milk. So you're protecting your breastfeeding infant by getting the vaccination for yourself. So, bottom line is similar to what Dr. Berriman pointed out in terms of the best way to protect yourself and your KEIKI as individuals is to get vaccinated. But that's not the only thing. It's also the best way to protect family members and friends of those individuals that got vaccinated. And it's the best way to protect our community, especially those that are immunocompromised and those that aren't able to get the vaccine. It's the best way to just protect ourselves in general as a community. And thank you. That's all I have.
Great. Thank you both for the wonderful presentation. So we have some questions. I think we have a lot of time for some questions. So the first one we were asked, and this one isn't really directed to to anyone, so you both can answer. Can we give ibuprofen to our KEIKI prior to the COVID vaccination to alleviate the pain in their arm?
It is not recommended to give ibuprofen or Tylenol before you get the vaccine, but you can certainly give the Tylenol or ibuprofen after you get the vaccine if you were to develop any symptoms from the vaccine. But no, it's not recommended to give it before the vaccination.
Do you anticipate that youth will need to receive boosters later on down the road, similar to adults?
I think, I saw Dr. Berriman was going to open her mouth, so.
You go ahead.
I think that's just going to have to come with ongoing studies, and it's just something for everybody to be mindful of, that these COVID vaccines are probably the most studied medications in the history of human medicine. So as we gather more data, as we discover whether there are new and changing variants that circulate and how long immunity lasts from the vaccine, there will later be recommendations or not of boosters. And I don't know if Dr. Berriman has anything to add to that.
I would just add that for the mRNA vaccines, the evidence right now is for vaccine in people who for a booster dose in people who are either at very high risk or may not have mounted as strong an immune response. So those 65 and older, those with underlying health conditions, are at high risk of exposure. Healthy adults 18 to 64 who had the full series of mRNA vaccine do not need to have a booster. There's no evidence that it's required. It's not a shortage issue. It's just there's no evidence that it's needed. I would expect that children will fall into that same category. There may be subcategories who are at higher risk that we learn need to have boosters, but I don't think we should be anticipating a booster recommendation in the near future for these young children.
Great, thank you for that. If a child has tested positive for COVID-19, is there a wait time before the child can receive the vaccine?
The only wait time is that they have to make sure that the child has recovered from the infection and recovered from what's referred to as a transmission risk. And that's typically 10 days after symptom onset. No fever for at least 24 hours without fever medications, and symptoms improved. After those criteria, the individuals can get their vaccination without running the risk of exposing anybody at a vaccination site.
When kids are vaccinated, should they still continue to wear masks and social distance? Any thoughts on that?
Public health comment, Dr. Berriman.
I'll comment. Vaccinated children should be considered like vaccinated adults. So we know that vaccinated adults should still take reasonable precautions. Vaccines are not 100%. We don't have any vaccine in our armamentarium that is 100% effective. So we need to continue taking reasonable precautions. And that applies to children the same as it does to adults.
Thank you. Given the data that we have about people who get vaccinated, what is the likelihood that adults who chose not to get vaccinated are choosing to get their children vaccinated? I know it's like a hypothetical, but any thoughts to that question?
Doug, you may know more than I. I know there's a lot of survey data that the hesitancy or reluctance among parents to vaccinate their children is, if anything, even greater than their hesitancy or reluctance to vaccinate themselves. So I think that we all know that there are many people who have concerns about this, and that's part of why we're doing so much to try to get accurate information to as many people as we can, and why on the public health side, we really rely on our pediatric and healthcare providers, because we know that that's where parents tend to have the most trusting relationship around health issues.
Yeah, that's absolutely right, Dr. Berriman. I have not seen any data where a vaccine hesitant parent is interested in vaccinating their child. I would presume that if a parent feels that it's in the best interest of their child to get vaccinated, by proxy, it would be in the best interest of themselves to get vaccinated. I would suggest everybody getting vaccinated.
Absolutely.
What advice do you both have for parents to teach their kids about communicating about vaccinations?
Wow.
The part two to that question is, should children ask other children if they are vaccinated?
I'd like to say, sure, children should be happy to ask and volunteer that information, and I hope they will be. I also know that this is an issue that is so charged in some of our communities that to do so may really risk, I wanted to say we don't want to be instigating playground fights or anything. So I think that the parents need to gauge that by the circles in which their children socialize and by what the issues are. I think if parents are concerned about the safety of their own children, I would see it as a parental responsibility to ask about the vaccination status of friends and others that kids are around, in the same way that as pediatricians, we recommend that parents ask about other kinds of safety issues at friends' houses, guns in the household and things like that. So I don't know, Dr. Kwok, if you have anything to add.
No, I agree. I think that was a great response, Dr. Berriman.
Awesome. If a child is only 2 months away from their 12th birthday, do you advise they get vaccinated with the 5 to 11 dose or wait to get the 12 and older dosage? Will children who are vaccinated with the 5 to 11-year-old dose need a booster after they turn 12?
Yeah, no, I would say don't wait till they turn 12, because those are a couple months where your child is unprotected when the vaccine was available to them. The way the vaccines are done is it's based on the age at the time of the vaccine. So if you're 11 years old when you get the first vaccine, but you become 12 when it's time for your second vaccine, at least 21 days later, then you will get the 12-year-old adult vaccine. There has not been any data yet on whether they would need any booster or not, but the studies have demonstrated that there is effective protection on the doses based on the age groups.
I would really emphasize Dr. Kwok's point. There's no need to wait for your child to have a birthday. The best thing to do if you want to protect your child's health is to get them vaccinated at the dose they're eligible for as soon as you can.
Thank you. This is a question we received. What do you say to a parent who says that because children are not at a greater risk of getting infected, hospitalizations, or dying from COVID, why should they vaccinate their child?
I think Dr. Kwok and I both addressed a lot of reasons for that.
Yeah, and there are different slants to that, a public health slant and a very individual slant. I think it's been pretty clear that children can get infected just as much as adults can, and that means they can spread the infection just as much as the adults can. Just because they tend to get milder infections don't mean that they can still get infected and transmit in the community. So, I would still recommend the vaccination. And then the broader thing in terms of community responsibility is that, we do know we have individuals in our community that for whatever reason cannot get the vaccine, or despite getting the vaccine, don't mount as good an immune response. They might be immunocompromised. They might be battling cancer or other medical conditions. And those are people we need to protect as a community. And by getting our KEIKI vaccinated, we can offer our larger level of protection for our community.
Could I piggyback on that?
Mm-hmm.
So early on in the pandemic, we did a lot of talking about herd immunity, and we're not talking about it so much now because it looks like the level of protection in the community would need to be so high that we're not optimistic that we'll reach that soon. But the greater percentage of our population, our entire population, that is vaccinated and immune, the less spread and transmission we will have in our community. And that means fewer restrictions, fewer things people are going to tell you can't do, and fewer requirements to do the things that you want to do. So another part of that community piece is that the more highly vaccinated our whole community is, the more we'll be able to do quote unquote normal activities and the things that we've all missed.
Great, thank you. Dr. Kwok, this is for you. Can you review again why boys are at a higher risk for myocarditis?
Not sure, and even why even that age group is at a higher risk than other age groups. It's something that there are ongoing studies for. It's just something that came up in the studies in terms of statistics on the higher incidence in that population. And that's something that they are desperately looking to gather more information on.
Great. We had another question. What are the common long-term COVID complications in children? I think Dr. Berman, you had that portion in your presentation. Could you just review a little bit again?
I had a slide, but I think Dr. Kwok may be more knowledgeable on this issue than I am. I know that it's a lot like it is in adults, and that it can involve fatigue, pain of all kinds, and actually also cognition changes in your ability to think and to focus and to concentrate, and in your mental health, which are they would be particularly concerning to me if my children were in this age group. Dr. Kwok?
Yeah, that's right. And it's a lot of it is just a lot of these individuals just feel like they're walking around in a brain fog in terms of cognition for weeks to months after their COVID infection. And you're right, the fatigue and the pain can persist as well too.
Thank you. When do you both know, or have any idea of when will COVID vaccines be available for ages 2 to 5? Like to be approved for ages 2 to 5?
They are studying. Sorry, go ahead, Dr.
No, you go ahead.
No, they are studying. So the next age group to study is 6 months up to 4 years of age. But the tricky part of that is they're also looking at dosage adjustments, similar to how they looked at the dosage adjustments for 5 to 11-year-olds. And whenever you add a dosage adjustment, you add an extra layer of complexity to performing these studies. So I would say there is nothing on the horizon in terms of getting a vaccine out for 6 months to 4 years of age, but know that there is definitely work being done on studying the vaccines to get authorization.
Dr. Berman, did you want to piggyback on that?
I was going to say, this is where I get to say my crystal ball has been foggier in this pandemic than I wish it were. I don't have anything to add.
Okay. Do you both foresee schools requiring COVID vaccine in order for kids to attend classes? And supplement question is, do you know which schools plan to offer the vaccine as of right now?
So school requirements, so private schools can make whatever requirements they want. DOE schools, that's a state process and decision, and there's a very clear and very transparent and very community involved process for introducing new vaccine requirements in school. There were some adjustments to the vaccine requirements in our DOE schools a couple of years ago. People may remember in-person hearings on all the islands, multiple opportunities for public input, a work group that makes recommendations. So that's not in the works now, but when or if that is in the works, it will be a very public and participatory process. The second part of the question was, what schools are offering it? The Department of Health and the DOE both have extensive information about that on their websites. I will say that it's not the schools themselves that are offering the vaccines, but the schools that are making space and working with healthcare providers to provide the vaccines on their campuses. And to anticipate a question, on Kauai, we're, as usual, doing things a little bit different. Our schools and our healthcare providers together reached the same decision for these young children as they did for 12 to 17-year-olds, that actually would work best for our community, for parents to bring their children to the healthcare facilities for their vaccines. So our healthcare partners are offering evening and weekend clinics and all day long clinics and walk-in clinics and appointment clinics in order to make it as convenient as possible for parents. So right now, Kauai looks a little bit different, but there are vaccines being offered in schools throughout the state.
Thank you. Will vaccination provide protection from variants for KEIKI? Another part to that question is it also true that the more of our total population that gets vaccinated, the less chance for a dangerous new variant to develop?
You want me to? So in terms of the development of variants are part of the normal evolutionary process of viruses. And the more frequently a virus reproduces, the more it replicates, which it does when it infects people, the more chance there is for a variant to emerge. So I think that when we're thinking about the likelihood of variants emerging, we need to be thinking about the global picture of COVID replication and spread, and the parts of the many parts of the world where almost no one or very, very small percentages of the population are vaccinated are at the highest risk for variants emerging. And then, of course, once they do emerge anywhere in the world, we are at risk for them coming here in the same way that we have been for all of them that have preceded us. Dr. Kwok, maybe you want to talk about vaccines and variants?
Yeah. I would just dovetail onto one of your comments in that this is what viruses do. Viruses replicate. And the best way we can as a community to decrease that replication is to vaccinate the community. The more protected people we have in the community, the less the virus can replicate in the community, the less likelihood that there is that a viral variant will develop. But this is what they do. What we know to date is that the vaccines have been effective with the circulating variant strains. We just do not know what might come down the pipe, which is why the interest in getting as many people vaccinated as we can, so that it minimizes the chance of the virus to replicate, to create more variants into the future.
Great, thank you. One question we received was, can kids get the COVID-19 vaccine and the flu shot at the same time?
Absolutely, yes.
Perfect. Great. Yes, I like that. Clear, right to the point. And then one last question, to clarify, what is the dose for the 5 to 11 age groups? You said it's 1/3 of the adults, but is it 0.2 or 0.1?
So the dosage is 10 micrograms. The adult dosage is 30 micrograms, but I believe the volume is the same. Dr. Berman, do you know?
I think, oh gosh, I will not say. I thought it was half the volume, but I may be thinking about the booster dose, so I won't say. I have been told that it's a smaller needle and a smaller syringe, if that helps anybody, but most kids who are afraid of needles don't really care how big the needle is.
So the gist is it's 1/3 of the dose. The adult dosage is 10 micrograms, and the 5 to 11 dose is, the adult dose is 30 micrograms, and the 5 to 11 dose is 10 micrograms.
Great, thank you. And sorry, one last question. This is our last question for our webinar. Where can parents find multilingual resources? Where would you recommend they go?
I believe the Department of Health has multilingual resources. I don't know that they've all been translated specifically for information about the 5 to 11-year-olds, but I know that the Department of Health and the district health offices have multilingual staff who can have conversations with people in just about any language you can come up with.
Yeah, that and the CDC and the FDA also have multiple languages. The FDA publishes the emergency use authorizations information for recipients in multiple languages. So you can go to those websites to print out the information in whatever language you're interested in.
Awesome. Well, that's the end of all of our questions. And I want to thank you both so much for being our guests for today. I want to thank you all who've joined us on Zoom, all our participants, and lastly, our Hi-Fi staff that have been helping behind the scenes. Please save the date for our December webinar, which will be on December 1st, and we will share those details at a later time. So again, mahalo to our guest speakers, Dr. Kwok and Dr. Berman, for sharing their knowledge with us. Be safe, be well, and we hope to see everyone at our next webinar. Aloha.
Aloha. Thank you so much for the opportunity. Bye.